Hello and good afternoon friends, welcome to the CEC EduSet live lecture. Dear friends, as you know that in recent past we have conducted numerous lectures on cancers, on the types of cancers, and I believe that those lectures were very beneficial for you. So dear friends, for you once again today in this session we are going to talk on another type of cancer, and the cancer is lung cancer. Dear friends, we always say tobacco is not good for health. So today we are going to discuss how tobacco affects our lungs and further causes lung cancer. So dear friends, for this we have again with us in our studios Dr. Majid Ahmad Talikoti. Dr. Majid Ahmad Talikoti is a chief oncologist, and I believe that you might have seen his previous lectures on cancers with the help of this EduSet platform. Today also we are going to grab maximum knowledge from him, and this lecture is also going to be one of the finest lectures. So without wasting any time, I would like to welcome our guest Dr. Majid Ahmad Talikoti, and under his able guidance we are going to learn about lung cancers. Hello sir, welcome to the EduSet lecture.
Hello, good afternoon. Yeah, it's a great pleasure to be here, and today we are going to talk about one of the deadliest cancers, meaning to say the most number of deaths in the world are due to this cancer, the lung cancer. And as we all know that cancer today is treatable, curable, and above all it is also preventable. To begin with, lung cancer is largely a disease of modern man. In 1900, this was very rare. And what probably the cause could be, what we could think of is that the use of tobacco in those days was hardly anything. Raymond Pearl's landmark 1938 report conclusively established the devastating impact smoking has on longevity, and for lung cancer, the most important culprit is nothing but the consumption of tobacco. But there are, like, if you see 60% of the new lung cancers, there may be few of them who have never smoked. Out of 5 women, one may say that she has not used tobacco or smoked, or 1 in 12 men may give a history who has been diagnosed that yes, the tobacco was not used, but still, nonetheless, in 90% of the cases, if the history is taken, they always give a history that there is some association with tobacco. Nevertheless, there are patients who say, okay, we have never used tobacco, but still I have developed a cancer, I have developed a lung cancer. Yes, for 90% of the time, tobacco is the cause. 10% of the time, there may be some other causes like pollution, like for example, the burning of charcoal at home, and many other causes like this, working in the factories like the asbestos factories and all that. So there could be many other causes, but let us discuss about the main cause first. And before that, just to give a brief introduction how tobacco is being notorious. In India, we have an approximate population of around 120 crores. 30 million people use tobacco. And if you go by the studies, the literature, the information what we have, 50% of the male cancers are because of tobacco, and 25% of the female cancers are because of tobacco. And this ratio male to female is changing, and the female cancers are increasing, and one of the main reason is the use of tobacco in females is also increasing. We also know that, like for example, other than lung cancer, like for example oral cancer, India is the capital. Means maximum number of patients are found in India, because in India also, along with tobacco, not only they use in the smoking form, but they also chew tobacco, which is also equally and more dangerous than smoking tobacco. And hence, who are, if you see today's in the society, our young children, especially if you see the incidence of, for example, people who are using BD or cigarette, the number of them, you'll be shocked to know earlier it was somewhere around 25% before the age of 10 years. Now, the initiation of BD smoking in less than 10 years of age, that is in young, tender children, has increased from 26% to 45%, which is a bad sign, and which is going to increase the number of lung cancers in future, increase number of not only lung cancer but also heart diseases and chest diseases, lung diseases, and so many diseases which are caused because of tobacco. All the incidents of that means we are heading towards a non-healthy future. Those people, those who have used 20 cigarettes per day for more than 20 years, there's 70 to 80% of them developing a cancer, especially cancer of the lung, larynx and oral cavity. And today we see nearly around 6 million people are dying because of the use of the tobacco. But in near future, maybe by 2020, this is going to increase more by another 25%. That means we'll have nearly 9 million people who will die from the use of tobacco. If 3 people are using tobacco, one among them is going to die because of either from the cancer or either from the lung diseases or a heart attack or a stroke. So we should, have a tobacco-free environment. We should have a tobacco-free Delhi. We should have a tobacco-free India and the whole world. Just to make you a little more interesting, in 2011, a data was collected how much amount was spent in treating diseases related to tobacco use. It was how much? It was not in something in thousands of lakhs, but it was 1,04,500 crores was the total expense which was attributable to tobacco use from all diseases in India. And the budget, or you can say the state and central expenditure over health, was even 12% lesser than that year's expenditure to treat the disease. That means the tobacco, a big culprit, a big waste of expenses, the waste of resources. So we have to do something for it to save our generation, ourselves from the tobacco. And also in America, the lung cancer is the most common cause of cancer death. There also, more than 220,000 individuals are diagnosed and died. Lung cancer is rare below age of 40, with rates increasing until age 80. That means if in younger age group the incidence is less, but as the age advances, that is from 40 to 80 years, as the age increases, the incidence of the lung cancer also increases, because it is directly proportional to your lifestyle, to the tobacco. The projected lifetime probability of developing lung cancer is estimated to be 8% among males and 6% among females. In India, if you study demographically or what's the incidence in the males, females, the rural, and which occupation it's common, it is seen in all religions, in all, especially in the age group. The mean age is around 50 to 55, and it is more common in males as compared to females, but now the incidence in females is also increasing. What are the risk factors? 80 to 90% of the cases, cigarette smoking is the common cause. Those who smoke, they have a tenfold or greater increase or risk as compared to a common man who does not smoke. If you use 15 cigarettes, one genetic mutation may occur, and that may lead in future for cancer. Any type of lung cancer, whether it's a small cell, non-small cell, large cell, can be caused by cigarette smoking. Even, for example, I'm not a smoker, but if I am in the environment where there is cigarette smoke or where there is smoke, it is seen that even I will develop, because I am in that environment, I may develop the lung cancer, I may develop problems related to the tobacco. That means environmental tobacco smoke or secondhand smoke is also an established cause of lung cancers. Husband smokes, wife doesn't smoke, or the other way, the other partner develops the disease. This is one of the reasons. That means even passive smoking or secondhand smoke or environmental tobacco smoke, all is dangerous. As I told you, that in Indian patients, we normally take the history when a patient comes, have you smoked, have you used tobacco in any form or no. In 87% of the males, they concluded, yes, we have used tobacco in some form and some part of their life. And 85% of the females also said this. And as the passive tobacco as I explained, means I am not a smoker, but still I am sitting with friends and all those things, and the smoke is going into me. That means I am not actively smoking, but I am inhaling it. So 3% of the people who developed cancer also had this type. So that means in 90% of all cases in India resulted from tobacco exposure. The relative risk of developing lung cancer is 2.64 for BD smokers, 2.23 for cigarette smokers, and 2.45 for overall relative risk. Yes, the tobacco is the culprit. Risk of cancer is directly related to the amount consumed and duration of habit. That means if you are decreasing it, stopping it, that means your risk is going to come down. If no, if you take the more number of times, the more number of quantity you take, and for the more number of duration you take, that much is the higher risk. We all know for oral cancer also 90% tobacco is the cause, for lung cancer also, larynx cancer also, and many cancers like even breast cancer, bladder cancer, renal cell carcinomas, everywhere tobacco can be one of the cause. And if you combine tobacco with alcohol, it's a very deadly combination. That means, it's going to be much, much, much more dangerous. And if you see the incidence of cancer in male and female, earlier it was somewhere around 1:6, 1 male, 6 females. Today it is 2:1. Why? The tobacco incidence, tobacco use, tobacco abuse has also increased in females. Just to say, though, what tobacco is, and although everyone knows it, everyone knows it's a culprit, the government knows, the politicians know, we all know, we businessmen know, we doctors know, we patients know, we children know, but still we pay a deaf ear. Because why? We feel so many lakhs of people are working, it is their industry, they need their bread and butter. That means dacoits also are doing the same thing. What I mean to say is, what is right, what is wrong is wrong. What is ethical. That means if tobacco is a killer disease, it is like a murderer disease, then it should be treated irrespective, keeping inside who or how much benefit it is giving. That means there are more patients coming, the doctor is earning more. That means he should encourage it? No. There should be a strict law. We should think for the welfare. As I told you, that the incidence in children, our young school, young children who are coming up, you see, they are catching up with it because of the maximum publicity, advertisement and all that. Really, we need to do something for it. If you see the tobacco in smoke, for example, BD, cigarette, cigar, hookah, etc., all this can cause lung cancer. And as I told you, something is much more dangerous, that is smokeless tobacco, gutka, zarda, khaini, pan masala, oral absorption. All this tobacco has around 7,000 chemicals, 100 are highly toxic, 70 toxins which can cause cancer. Because it contains nicotine, carbon monoxide, tar, tobacco-specific nitrosamines, ammonia, and so many, toxins which can, cause cancer. Yes. See, after everyone who would not like to quit, but it's always very difficult to leave a habit which we have calculated it. And it's very simple how I get a habit. I'm not a tobacco, but when I go in a marriage, I use some, thing where little a bit of tobacco flavor is given to it, like maybe in the form of a pan or some maybe, some appetizer or something. Slowly, you start taking it more number of the time. Then what happens, you start putting little tobacco into it. Then you start, developing a habit. Then you become dependent. Then you cannot live it. Now, earlier you had control, now it has control over you. So to quit is not an easy, but just a few ways how we can go ahead by quitting it. We should first pick up a date that yes, I want to quit smoking. And then once you do it, you should stick to it. But sometimes you break it, don't worry, start it again. Okay? The battle is not lost till you, start trying and winning it. Then we keep trying it. Don't lose heart. Nothing has happened. What are the benefits also? I will tell you later if the time remains. What are the benefits if you quit also? You should make a small note. Write down your reasons why you want to quit. Read over the list every day why you wanted to quit. For your children, for yourself, for the society. Here are some tips you should think about. Write down when you smoke, why you smoke, what makes you smoke, in which environment you smoke, and try to cut short those things. Stop smoking in certain situations, such as you have a habit of taking a break, going for after dinner taking it. So try to initially stop that before quitting it. Make a list of activities you can do instead of smoking, like playing, watching a movie, going around with friends or some other activity, a hobby which you enjoy more or equally, a little less, so that you can concentrate on those things. And very well you can make use of the doctors. We are always there to support and, try to, go ahead together and try to stop and quit it. See, tobacco not only causes cancer, but not only cancer of the lung, but also of the oral cavity, larynx, esophagus, etc. Okay, it also causes lung diseases like COPD and all those. Heart attacks, yes, tobacco is the cause. Decay and fall of teeth, submucosal fibrosis, and so many things are there. It is tobacco use is something like a suicide. Quit tobacco. Avoid. Initially make it to half, 1/3, and go ahead stopping it. Don't come back. Whenever you have a craving, it is for few minutes. Divert your attention, as I told you. Take the help of doctors, your friends. Avoid situation of temptations. But for all this, you need a very strong willpower to go ahead, and you should notify all of them that you have quit it, so that they don't come and tell you start. Okay? You become a role model so that they looking at you, they also stop it. You should avoid trigger factors. Encourage yourself in yoga, walk, exercise, and all that. By chance you happen to smoke again, don't worry. Start it again. This happens. It is something you are going on a road, you come down, do you leave the road? Come back on the right track. Go ahead, stop it again. Now, I was concentrating on tobacco. Why? I told you a little more. Because tobacco is 90% of the cause for lung cancer. Now, other reasons, people say we have not used tobacco but we have developed lung cancer. What is the cause? These could be few of the reasons why you developed a lung cancer. For example, people who are working, occupationally involved in where asbestos, arsenic, nickel, or radiation exposure is there, or you are into hard rock mining where there's a lot of dust, okay, and chloromethyl, ethers and mustard, soots, stars, oil and coke companies, factories, mines, where the exposure of these materials like asbestos, arsenic, nickel, and all is there, or where radiation is there. All this could also be, especially in Delhi or in nowadays, the pollution of the vehicles. And earlier olden days where we used to have those chullas, where we used to burn the coal, to cook. Now so all the smoke can also be one of the cause for the lung cancers. And it has also been shown that, if you use more of fruits, vegetables, and this has got, good of the immunomodulators and immunity boosters, which can help you. So I say like we should encourage ourselves with a good diet, fruits and vegetables. And, if you have these ionizing radiations, we have heard in Japan, Hiroshima, Nagasaki, bomb was blast, nuclear bomb. And there, if you see in that area, the incidence of cancer, is very high. Incidence of lung cancer is also high. Why? Because the detrimental effects of the radiation hazards. So we should avoid radiation exposures. Even that could be one of the cause for the cancers. Prolonged exposure to low level of radon in homes, radiations at homes can also be, one of the causes. People who have suffered or are suffering from chronic lung diseases like tuberculosis, emphysema, chronic bronchitis, this can also, be one of the reasons for developing lung cancers because of the weak lungs, weak immunity. Air pollution is one of the causes for the lung cancers. And many studies, like even some studies in China have shown, as I was telling you, like we use coal, in many purposes. One was like, for cooking, even in today in rural areas, in villages, where still the burning of wood or coal is being used. That smoke also can be one of the reasons for the cancers. Yes, we have discussed smoking cessation is very important. We as physicians must promote tobacco abstinence, to quit tobacco, and to make others also to quit, and tell them, recommend them, tell them the advantages why tobacco should not be used, how you will die, and how you can save yourself, and how can you save your family members. Stopping tobacco use before middle age avoids more than 90% of the lung cancer and diseases. Smoking cessation is definitely beneficial to individuals even with an established diagnosis of lung cancer. I have a lung cancer. Oh, the damage has occurred. Now what? Smoke. No. If you stop smoking, it can help you. Essential elements of smoking cessation therapy. The individuals must want to stop smoking. When I have a will, then only I can do it. When I don't have a will, I cannot do it. So there are many therapies also which we normally give: antidepressant therapy, nicotine replacement therapy, just to support during the weaning period. There are certain inherited predisposition to lung cancers. Environmental carcinogens can induce or facilitate the transformation from bronchoepithelial cells to the malignant phenotype. So, like the first degree relatives of lung cancer patients, they have a slight increased risk, like 2 to 3-fold, because of the same environment, and many of which are not smoking related. There are certain inherited mutations like the retinoblastoma gene P53, three genetic loci like the 5p15, 15q25, 6p21, EGFR mutations. What is lung cancer? The lung is made up of the principal bronchi, then the tertiary bronchi, then the bronchioles and the alveoli. If these epithelium changes, then the lung cancer develops, like the bronchogenic cancer. In lung cancer, we have different histologies. The 4 important histological factors are: the most common is the non-small cell lung cancer. It has 2 components. One is the adenocarcinoma, which is very common in the European setup, and in India still squamous cell carcinoma is the most important histology. So the non-small cell carcinomas, lung carcinomas, are the most common, in which we have 2, adenocarcinoma and squamous cell carcinoma. Other than this, we have the small cell lung cancers, which is around 20%, and we have the large cell carcinomas. Among them, as I told you, in the Western countries, adenocarcinoma is nearly the 50%, and less 3, the non-small cell carcinomas, like the squamous and the large cell and the small cell contribute. If you see the Indian graph, squamous is common, next common is the adeno, and then the large and the others. Among women and young adults, here also the commonest histology is adenocarcinoma. In people who have never smoked, in them also adenocarcinoma tends to be the predominant cancer. The incidence of small cell carcinoma is on the decline. In India, if you see the lung cancer, non-small cell lung cancer constitutes, that is the adeno and the squamous, together constitute nearly 80% of the lung cancers. And the bad part or the worst part is, regarding any cancer in India or the lung cancer, is that nearly 70% of them, they present to us in stage 3 and 4, where the curative surgery cannot be done in these cases, where nearly 70% of them especially in the stage 4, do not complete 1 year. That means in India, our diagnosis, not only in India, but in most of the world, but in India if you see, it is, that means out of 180 cancer patients, lung cancer patients, they are diagnosed in 3rd and 4th stage. That means last stage. That means we have lost the precious time, where in stage 1, where it could be totally curative, in stage 2, stage 3, where we could still give better and better results, we are seeing in the last stage. How can we see and try to get all this 80%? Our aim today should be to convert that we should be able to diagnose 80% of them in stage 1 rather than diagnosing them stage 4. How can that be done? That can be by awareness, like these type of lectures, by awareness in hospitals, in schools, by having specific topic over that, or having some advertisements like that, and especially having a strict screening protocol. Means those individuals who are more than 40 years and those who are smokers or use tobacco, or in their family if there is a risk of lung cancer, so that they can get themselves screened and come to know that the person is not having cancer or has the can develop cancer in the near future. For the screening, so still studies are going on all over the world, but nowadays in screening we use low dose CT scans, which will give us an idea like how is there any nodule appearing, or is there already a nodule that could be a cancer. So we really need to do something to change this figure of 80% diagnosis in the last stage, and that can be done by awareness, that can be done by increasing the health facilities, by increasing the screening protocols. Now going to the next common cancer, the small cell lung cancer, which constitutes 20% of them, and very bad part about this cancer is also it is diagnosed 70% of the time in the last stage. That means the prognosis chances are less. And in Western countries, most of the Western countries, adenocarcinoma has become number 1. In India still we have the squamous 1. Now going to the small cell cancers. These are the poorly differentiated neuroendocrine tumors, most commonly in the smokers. They are highly prevalent. Incident rates are higher among men than women. And their presentation is like they have a central mass along the bronchus. They are centrally located tumors. They produce specific peptide hormones like ACTH, AVP, ANF, GRP. These hormones may be associated with the paraneoplastic syndromes, and the differential diagnosis could be for small cell carcinomas, or they could be poorly differentiated non-small cell carcinomas, neuroendocrine carcinomas, or the lymphomas, small round blue cell tumors, or sarcomas. This could be few of the differential diagnoses. Histologically, when we see, the slides look like this under microscope, where you have small cell carcinomas with islands of small, deeply basophilic cells with necrosis. Here, this is an FNAC from an enlarged lymph node, which shows clusters of tumor cells of a small cell carcinoma. You see the nuclear atypia, which is the characteristic of this tumor. Squamous cell carcinomas, they are similarly like how other extrapulmonary, like those in the head and neck, how they look. They are similar in behavior. They occur also centrally, that means along the bronchus, and centrally located. And usually the squamous cell carcinoma variants, they give a strong history of smoking. The pattern is that of an infiltrating nest of tumor cells with central necrosis resulting in cavitation. creatine can usually be seen when present. I'll just show you how it looks, and the differential diagnosis here could be squamous metaplasia. You see here how a well differentiated squamous cell carcinoma, which is showing keratinization. This is the cavitation within a squamous cell carcinoma. If you take a sputum, and here you can see the keratinized squamous carcinoma cells with a prominent hyperchromatic nucleus. Now moving to the adenocarcinomas. Adenocarcinomas, they are commonly peripheral in location, as in comparison to the small cell, in comparison to the squamous cell. It is the commonest type, especially in the non-smokers. If you see here, the gland-forming adenocarcinoma. This is a gross specimen. Bronchoalveolar carcinomas, it's a subtype of adenocarcinoma which grows along the alveoli without invasion, present radiographically as a single mass, as a diffuse multinodular lesion. This is how a bronchoalveolar carcinoma looks. The large cell carcinomas, these contribute 10% of the lung cancers. They also, like adenocarcinomas, are peripherally located. Poorly differentiated carcinomas, there are sheets of large malignant cells, often with associated necrosis. Cytologically, the tumor is also arranged in a synictyl groups and single cells, you can see. The variants of large cell carcinomas are basaloid carcinomas, lymphoepithelioma-like carcinomas. You can see here the large cell carcinomas featuring pleomorphic anaplastic tumor cells and absence of squamous or glandular differentiation. What is immunohistochemistry and how it is going to help us in the treatment of cancers? The diagnosis of lung cancer rests morphologically or cytological features which are correlated clinically and radiographically. Usually we have the EGFR, the ALK, TTF, these are the markers. And in squamous cell carcinoma, as you can see here, the positive immunohistochemical markers like the cytokeratin, etc. And in adenocarcinoma also, the TTF, neuroendocrine markers. In the large cell carcinomas, the neuroendocrine markers, cytokeratin, TTF. So these are the positive immunohistochemical markers which we get. So by this we will come to know the exact cell of origin for lung cancers, which is not, today after so much of this also we are still not sure the exact cell of origin from which the lung cancer is known, but still it is type 2 epithelial cells which give rise to the tumors. The oncogenes, as I was saying, in adenocarcinomas like the EGFR, KRAS, ALK, squamous cell carcinomas, EGFR. Why I am discussing about these are because these sometimes in stage 4 also, these oncogenes, when we give a specific targeted therapy, the results are really good. So these are of importance for targeted therapy. Even we have seen with stage 4 patient of an adenocarcinoma in whom EGFR is positive or ALK is positive. We have given crizotinib, or we have given them the results like with the geftinib and all, they're really good. Means the stage 4 also, we are able to extend the lifespan, we are able to increase the quality of life. That's how the medicine is changing. So for these, all these markers are very important. The best part in the treatment is, if you want the best result, if you want to reach our goal, as I was telling you, we today 80% are in last stage, third or fourth stage. If you want them to be in first stage or second stage, where we can, treat well, where we can have cure results, for that early detection and screening is very important. That means we should be able to detect the disease in the beginning, where it is, what do you mean by early stage or stage 1, where the disease is, like for example, only in one part of the lung. There are no nodes. It's a small lesion, maybe around 2 centimeters. It's just the beginning. Stage 1, where you can just, cut it off and remove it, or where you can ablate it, or a little more, like, there is a localized disease and maybe small nodes in the nearby areas, like in a stage 2. But when it becomes locally advanced, when it is spread or a metastatic or a stage 4 disease, the prognosis keep coming down. But with treatment, even in stage 4 disease today, the quality of life, the survival is also increasing with the recent medicine. So early detection and screening should be given importance. Any person who is having cough, or who is having cough which has not subsided for 15 days, or those who are throwing out blood, hemoptysis, a major challenge confronting advocates of CT screening, because sometimes we may have false results. It appears that nodules, like for example, I have done a CT scan to do a screening, and I have found a small nodule which is around 5 millimeters, 5 to 10 millimeters. Now I am in a doubt, I don't know what it is and all. So sometimes we may have this, but if you do a screening, if you do a proper early detection, then your results, like for example in stage 1, will be more than 90%. So we should concentrate on early detection and screening. Those who are susceptible in families, those who are suffering from lung cancers and all, those who have been smokers for a very long time, and those who think they are at high risk should undergo screening. Screening with X-ray, the better modality is by a low dose CT, where we will be able to pick up the nodules, we will be able to pick up the disease early. When you go for it, you are aware, you know about the symptoms. If you have any symptoms, what are the symptoms, I will be telling you. When the symptoms come, it is not the early stage. Usually the cancers, initially in stage 1 and 2, they are not symptomatic. But we should never neglect the symptoms. What are the symptoms of a lung cancer? A person may have a cough which is for 15 days to 7 days, that's okay. But a cough which is not, you are not getting rid of, after taking treatment also it is not taken care of, then it really needs an attention that it should not be a cancer. If a person is having chest pain, it could be cancer, lung cancer. If with the sputum blood is coming, hemoptysis is there, then it could be lung cancer. Person is while walking and all, is dyspneic. This could be also one of the symptoms. If you are developing bone pains, clubbing, if there is a fever or weakness, or there is difficulty in swallowing, dysphagia, maybe the nodes are compressing there, or there is meaning to say these symptoms like cough, weight loss, dyspnea, chest pain, hemoptysis, bone pain, clubbing, fever, weakness, dysphagia, etc. You should not neglect them. If the symptoms do not resolve in a week to 15 days time, you should go, you should check, you should ask yourself and your team whether am I suffering from any disease. And when we, as a doctors, we take a history, we should always elicit whether there is a loss of weight, whether there is musculoskeletal pain, whether there is headache, there is any seizures or weakness, And when we examine, we should look for the lymph nodes as doctors. And we should see whether there is any, when the person who is talking, has he got any change of voice? All these things should be taken care of. Sometimes they may be, for example, if a person is having dysphagia, what could be the cause of dysphagia? That is difficulty in swallowing. Maybe the mass is compressing. If the person is having hoarseness, change of voice, maybe the recurrent laryngeal nerve is getting involved. There is Horner syndrome, that is anophthalmosis, ptosis, anhidrosis, etc. Is there pleural effusion? That means breathlessness or pain in the chest is there. Or, heavy, for example, like if there is an effusion or tamponade, that can also occur. So all this, as doctors, we need to, look into all these things, whether the patient who has come is having all this. So sometimes there will be skeletal symptoms like the clubbing, hypertrophic primary osteoarthropathy, cutaneous manifestations like the skin changes, or there may be sometimes neurologic symptoms like the myopathic syndromes, peripheral neuropathies. Sometimes there may be hematological manifestations as a part of the syndrome, like the migratory venous thrombophlebitis, DIC, etc. Now, we all know why cancer has a tendency, means to be, like for example, in lung the disease starts, it goes nodes, it goes to the different parts and different organs of the body, which we call as metastasis. And the spread of disease. An important feature which makes any cancer a killer disease is the metastasis. And we have commonly seen that even, this how it metastasis. What happens? The tumor cells are put in the blood vessels, in the blood streams, and the blood, wherever it goes, the disease spreads there. For example, like there is a nodal spread through the lymphatics, there is a hematogenous spread. For example, likewise, in lung cancer, the commonest site of metastasis is the adrenal gland. In 50% of the patients, the metastasis occurs to the adrenals. And other than this, the liver, brain and bone are the commonest sites of metastasis in lung cancer. So what we do is we always keep screening. Like for example, if a person of any cancer comes, we always still go for a PET CT. And what are the investigations to be done and all? I'll just go ahead. So now a person has come with a history like yes, and you think that this could be lung cancer. How am I going to diagnose this? What are the things I should do? The disease in the lungs, and as I told you, most of the cancers, they're centrally located. The tumor is centrally located. If I need to treat it specifically, today even stage 4 lung cancers are treatable and at times they are curable. Why? Because of the targeted approach, because of the good chemotherapy which is there. What we do is, now I have to, to confirm, like for example, I'm cooking a rice. Unless I take a grain of rice, I don't know whether it is cooked, what it is, how it is. So for that, what we normally do is to confirm. First, we do an imaging sort of a thing, like for CCT chest, abdomen, or PET CT whole abdomen, that is like an imaging. Now, to pinpoint it, is it cancer? What type of cancer? And which, like for example, lung cancer, I told you, non-small cell, small cell, large cell, others. Okay, now I want to know whether it is non-small cells because the treatment is different. The treatment modality is different. To confirm, to know what exactly it is, what I can do a bronchoscopy. With a scope I go and do an FNAC or I take a biopsy from that area. For centrally located tumors, bronchoscopic biopsy or EBUS is better. For peripherally located tumors like in the adenocarcinoma which are peripherally located, in those patients, a thoracoscopic or a CT guided biopsy is better. And sometimes the nodules are very small, you're not able to get after doing twice bronchoscopy or this, then VATS, video assisted thoracoscopic biopsy, is the best procedure. And especially in small tumors, 2 centimeters tumors, you can go ahead directly, excise it and come out. so that you are also curing the patient. Or you can, at times, you can use stereotactic ablation radiotherapy. So by these, by the CT, by the biopsy, and by the surgical techniques, we have come to know, yes, it is a cancer, it is of stage 1, 2, 3, 4. Now what next? After staging it, now I have to see if it's an operable case, whether the patient will tolerate the surgery or no. For that, I need to know whether lungs are functioning well or no. I do a PFT, pulmonary function test, and I see whether his forced expiratory volume is good or no, whether his carbon monoxide, DLCO, okay, that is diffuse capacity for CO, or blood gas analysis, which will give me an idea whether he can tolerate or no. If I resect a part of the lung or the whole right lung, whether he will tolerate or no. So this is a very important assessment, because this will give us in the post-op period how will be the morbidity, how will the patient tolerate the surgery, how well and fit he can go. Do we need to build up the patient before this? Now we have come to know, we have staged, we have diagnosed, now we have to treat. What is the treatment of a lung cancer? Treatment, we know in all cancers is 3: surgery, chemotherapy, radiotherapy. Early stages, it's always surgery. In a locally advanced stage, we normally make use of all the 3: the surgery, the chemotherapy, the radiotherapy, because the disease is a little notorious at that stage. Now in stage 1 and 2, surgery, go in or through a video assisted thoracoscopy and remove the disease, or do a thoracotomy, go in, remove the disease, or you do a stereotactic ablative radiotherapy. Now when the disease is a little more, when the node is involved or the disease is of larger size, then we can think of giving chemotherapy, that is induction chemotherapy, but there are no randomized control which favor induction chemotherapy. And then what we do, we can make use of the IHC, what we were talking about, EGFR, KRAS, ALK, where we can, use this modality by in the form of geftinib or crizotinib and all that. And usually, for example, in a locally advanced stage 2, stage 3 disease, you have done the surgery, okay? Now since the disease bulk was more, there is chances that there may be microscopic disease in the blood. We make use of chemotherapy to get rid of the microscopic disease which is in the blood. Or we give them, like the geftinib or the crizotinib and all that, if that. So like this way. And when to give radiotherapy? When the nodes are, more bulky, when there is a locally aggressive disease. At that time we make use of radiation. And when during surgery the margins are nearly close, where there is R1 or R2 resection, but the survival in such cases is less. Then chemotherapy. Chemotherapy is doing wonders today in lung cancers. We have different lines of chemotherapy. For example, if you see, for us, first let's go the commonest, the adenocarcinoma, the pemetrexed, the paclitaxel, and after that, if it is EGFR positive and all those things, then they are really do a wonderful job. If it is a non-small cell, then etoposide, cisplatin, carboplatin, and all those things. And when the disease is in stage 4, and we say, oh, there's nothing going to happen, but that time, if the IC markers are positive, that time we can make use of them, and we have also in such patients good survival. So in resectably locally advanced non-small cell lung cancers, we can give concurrent CT-RT after the surgery. And how much radiation we give? We give normally around 60 gray, that is 2 fractions per day. Now, so treatment we know, it is surgery, radiotherapy, chemotherapy, all together as the stage advances, and initially it is surgery and radiotherapy. What are the advantages I would like to tell? See, if you quit smoking tobacco right now, after 20 minutes your blood pressure and pulse rate decreases, your body temperature of hands and feet increases, you start feeling better. Within 24 to 48 hours, the chances of heart attack start decreasing, ability to smell and taste improves. Within 2 weeks to 3 months, your circulation improves. Walking becomes easier, which used to find it difficult before. Within 1 to 9 months, the coughing decreases in most people, sinus congestion, fatigue, shortness of breath, all that decreases. Your heart disease risk starts dropping down after 1 year of quitting from smoking. If you quit smoking, within 5 and 15 years after that, your chances of getting a stroke or paralysis come down. And as years advance, after 10 years, and your chances of developing cancer, your chances of developing any lung diseases, heart attack, stroke, all come and become nearly normal after 15 years. So there are many advantages. So today, take a pledge that yes, I'm going to quit tobacco. And yes, it is a fact that lung cancer, though it's a deadly disease, it is definitely a preventable disease. And how can we prevent it? The only answer to that, 90% of them, we know the culprit is tobacco. Quit tobacco and significantly reduce your risk for all cancers. So there are many consequences of spit tobacco also. But now, how to win over, how to control lung cancer? I said early detection, screening, and other than that, there was a lot of going on, whether should we increase the pictorial picture from 40 to 85%. I would, if you ask my individual opinion, yes, we should. Because the more the awareness, people will not go for it. And I think there is no harm. By doing this, India will become the first country in the world to have such a, going against tobacco in a big way. And that will definitely, people, what they see, they believe. Okay, and yes, government is doing a good job by increasing the VAT of tobacco products, and I think this will also go a long way. And we should always disbelieve that if I take little tobacco, nothing is going to happen. No, tobacco is a killer disease. It will engulf you slowly or later. You should also quit and also encourage others to quit tobacco. I am strongly against ban of tobacco. We should also discourage advertisements related to tobacco.
With this note, thank you, sir. Thank you so very much for giving us a very, very brainstorming session, I would say, the way you delivered the lecture by telling all the viewers that nothing is impossible. If we pledge, if we think, yes, we can do it, then everything is possible. And as we always say that prevention is better than cure. So, first attempt for preventing the things, for preventing the disease to affect us. So, prohibit tobacco in your personal life, and if in any case, the lung cancer or any type of cancer affects you, then as the doctor himself said, yes, it is curable, yes, it could be prevented. Just you want to do is consult your doctor, consult the hospital you want to, and then see you can see the change in your life. Thank you, sir. Thank you so very much once again for giving us a deep thought into this very topic that is on the lung cancers. And dear friends, if you want to ask any question, then you can mail us at info.cc@nic.in, and if you want to have session on any other kind of cancer, then we would be happy to conduct a session on that particular kind of cancer. And if you want to access this lecture, then I would like to tell you all that very soon we are going to upload this lecture on YouTube, and with the help of that lecture you can access it a number of times you wanted. So thank you, sir. Thank you once again.
Thank you.